Picture a medical thriller, but the villain isn't a person. Instead, it's a microscopic, completely silent cascade of events that systematically shuts down the human body's entire cardiovascular system. That's exactly what we're looking at today. Welcome to The Explainer. We're going to track this biological villain, a life-threatening clinical syndrome known as shock, and see exactly how it hijacks our biology, leading to a catastrophic systemic shutdown.
Here's our roadmap for the breakdown. First, defining the shock syndrome. 2, classifying types of shock. 3, inside the septic shock cascade. 4, the 3 stages of shock. 5, multi-system failure and clinical signs. And finally, 6, a clinical case of sepsis.
All right, let's jump right into section 1, defining the shock syndrome.
The absolute crucial point we need to establish right away is that true or secondary shock is a lethal mismatch between oxygen supply and cellular demand. It is a full-blown syndrome of cardiovascular collapse. Basically, your body experiences this acute reduction in the effective circulating blood volume, and that leads directly to inadequate tissue perfusion. Essentially, your cells are just starving for oxygen. And if this goes uncompensated, well, that impaired cellular metabolism rapidly leads to death.
Now, we really need to contrast this massive circulatory crisis with what a lot of people think shock is. You know, when someone experiences sudden fear, severe pain, or some kind of intense emotional reaction, they might faint, right? Medically, that's termed initial or primary shock. It's just a transient, usually totally benign vasovagal attack that causes a sudden drop in venous return. It might leave you weak and unconscious for a few moments, sure, but true shock, secondary shock, is fundamentally different. We're talking about a severe systemic circulatory imbalance characterized by profound hypoperfusion and systemic hypotension. You don't just magically wake up from this without aggressive medical intervention.
Moving right along to section 2, classifying types of shock.
We generally group this into 3 major categories, plus a handful of others. First up is hypovolemic shock, which is literally just a loss of volume. Think losing red blood cells and plasma from a massive hemorrhage, or even severe dehydration. Second is cardiogenic shock. Here, the fluid volume is totally fine, but the heart suddenly feels to pump it, like what happens during a massive heart attack. Third is septic shock, which is driven by severe bacterial infections. There are also other types, traumatic, neurogenic, and hypoadrenal shock. But for the rest of this explainer, we are going to zoom in on one specific, incredibly complex target, septic shock.
Which brings us to section 3, inside the septic shock cascade. It's time to shrink down to the microscopic level. Let's walk through the cellular crime scene and see how bacteria actually hijack the body's own immune system to trigger this massive, paradoxical collapse. Septic shock usually kicks off with gram-negative bacteria. When these bacteria undergo lysis, when they break apart, they release a powerful endotoxin, specifically a lipopolysaccharide, straight into the bloodstream. This endotoxin acts like a homing beacon, binding to the body's macrophage and monocyte cells. These immune cells get overly stimulated and release just massive amounts of pro-inflammatory cytokines, specifically tumor necrosis factor alpha and interleukin-1. And here's where the ultimate sabotage happens. These heavy-hitting cytokines trigger extreme vasodilation and a terrifying jump in blood pressure.
If you follow the pathway here, you can see how hypoperfusion leads right down to hypoxic cell injury, which kicks the innate immunity into overdrive. Notice how the stimulation of macrophages in the center essentially splits. It drives the release of these cytokines. You've got TNF-alpha on the left, driving nitric oxide synthesis and free radicals, and IL-1 right in the center, leading directly to that profound vasodilation and systemic hypotension. So because of all these inflammatory mediators flooding the system, the blood vessels basically just open wide up. That's your profound peripheral vasodilation. The vessels become incredibly leaky, pulling fluid right out of the circulation and creating widespread inflammatory edema. But it gets worse. In a truly cruel paradox where the immune response itself causes the fatal damage, these toxins severely injure the endothelial cells lining the vessels. This triggers a horrific complication known as disseminated intravascular coagulation, or DIC. Essentially, millions of microscopic clots form throughout the tiny vessels all over the body, completely starving the surrounding tissues of the oxygen they're desperately begging for.
Okay, section 4, the 3 stages of shock. Now, shock is a progressive, continuous phenomenon. But to understand it, we can divide it into 3 distinct stages as the clock ticks down. Stage 1 is compensated shock. That's the body's initial, desperate protective response. Stage 2 is progressive, decompensated shock. This is where those compensatory mechanisms start to fail and systemic deterioration really accelerates. Finally, stage 3 is irreversible decompensated shock. This is the tragic point of no return. Widespread cellular injury is so severe here that no recovery can take place, even if you somehow managed to fix the original cause. Just look at how rapidly the effects escalate. Up top in the compensated stage, the body is forcing widespread vasoconstriction to protect the brain and the heart at all costs. That results in a really fast heart rate and cool, clammy skin. But as we move down into the progressive stage, tissue ischemia sets in. You start seeing mental confusion and lower urinary output. By the time we hit that final phase, the irreversible stage at the bottom, we are looking at hypoxic encephalopathy in the brain, acute respiratory distress syndrome in the lungs, and just widespread catastrophic cellular necrosis. The ultimate irony of shock is how the body's own protective plumbing measures eventually just fail entirely. Think about it. In the compensated stage, neural and humoral factors force widespread vasoconstriction. The body is essentially pinching the hoses to maintain enough blood pressure for the brain and the heart. But in the irreversible stage, severe anoxia actually damages the capillary walls themselves. The arterioles become utterly unresponsive to those vasoconstrictors, and they just progressively dilate. Even the heart becomes starved of oxygen, which causes it to release a myocardial depressant factor that further wrecks cardiac function. The entire plumbing system has completely collapsed.
Let's pull back to the macro view in Section 5, Multi-System Failure and Clinical Signs. When a patient actually enters decompensated shock, their biological machine is visibly shutting down right in front of you. This is characterized by the severe depression of 4 vital processes. First, incredibly low blood pressure. Second, a subnormal body temperature. Third, a feeble, highly irregular pulse. And fourth, shallow, almost sighing respiration. If you're looking at the patient, they present with a very pale face, sunken eyes, and cold, clammy skin.
Think of the body like a complex electrical grid that is just losing power block by block. Mapping this across the organs, the brain suffers hypoxic encephalopathy at the very top. Moving down to the lungs, about 50% of these cases develop ARDS, or acute respiratory distress syndrome, basically heavy, wet lungs filled with edema and those microthrombi we talked about. Down in the kidneys, they develop acute tubular necrosis, or ATN, which ultimately leads to anuria, where the body just completely stops producing urine. The gut suffers hemorrhagic gastroenteropathy. It is, in every sense of the word, a complete systemic failure.
Let's ground this with Section 6, a clinical case of sepsis.
Bringing all of this textbook theory into a real-world human scenario, our pathology text presents a pretty heartbreaking case. It reads, the woman underwent an abortion under poor hygienic conditions 3 days back and therefore developed serious sepsis. Her high-grade fever is a systemic manifestation of fulminant septicemia. Her unrecordable blood pressure and pulse, along with rapid breathing, are due to hypotension and metabolic abnormalities. She is unconscious due to metabolic derangement accompanying renal failure. Cases like this really bring the immense medical urgency and the absolute high stakes of septic shock right to the forefront.
So let's connect those dots. Let's map the macroscopic clinical signs we just read directly back to the microscopic damage we covered earlier. The patient bleeding from her gums, that's due to severely reduced platelets from that disseminated intravascular coagulation we discussed. Those microclots are literally using up all of the body's clotting factors. Her unrecordable blood pressure, that is the direct, terrifying result of severe cytokine-induced peripheral vasodilation. And her being unconscious is due to hypoxic encephalopathy. Her brain simply isn't receiving enough oxygenated blood because of the profound cerebral ischemia.
Which leaves us with a highly critical realization. Knowing the terrifying speed of this cellular cascade, knowing exactly how rapidly bacteria can hack the body's own immune system, turn it into a weapon that dilates blood vessels, forms thousands of microclots, and suffocates vital organs, how incredibly fast must medical intervention act to break this vicious cycle before hitting that point of no return? It really gives you a profound appreciation for the immense pressure that healthcare professionals face every single day to reverse this biological shutdown before it's simply too late.